Thank you for joining us today on the Anesthesia and Perioperative Medicine channel. This is Rebecca Jane Collins. Willkommen auf den Kanal für Anästhesie und Perioperative Medicine. Merci de nous avoir rejoints aujourd'hui sur la chaîne Anesthésie et Médecine Periopératoire. Gracias por acompañarnos hoy en el canal de Anestesia y Medicina Perioperatoria. Today, we are diving deep into a topic that is absolutely critical for our practice, the brand new 2025 guidelines for pediatric and neonatal resuscitation. This is a high-stakes, high-stress area, and these updates demand our full attention.
So here's how we're going to break it all down. We'll start right at the beginning, in those first moments of life, with neonatal resuscitation. Then, we'll build on that with the core principles of pediatric arrest. From there, we'll get into the real meat of the updates, what's new for 2025 in both BLS and ACLS. After that, we'll walk through the algorithms that guide our hands in a crisis, and we'll wrap up by looking at the cutting edge, with ECPR and post-arrest care.
All right, let's start at the very beginning, the delivery room. Those first few minutes of a neonate's life are just everything. We're talking about a profound physiological shift, and if things go wrong, the consequences can be absolutely devastating. That's why having a skilled responder at every single delivery is non-negotiable. What we do in these initial moments can truly set the course for a lifetime.
Okay, so the initial evaluation has to be fast. It's a structured process that boils down to 3 simple questions. 1, is the infant term? 2, are they breathing or crying? And 3, do they have good muscle tone? The answers to these, plus a quick check of the heart rate, tell us exactly what to do. If the heart rate is over 100 and they're breathing well, fantastic, we just observe. But if that heart rate drops below 100, or if they're apneic, we don't hesitate. We immediately start positive pressure ventilation. And here's the critical trigger. If the heart rate is still below 60, even with effective ventilation, that's our cue to start chest compressions.
Now, once we're in a resuscitation, every action needs to be precise. For the airway, it's all about that sniffing position. And please, avoid deep suctioning in a vigorous newborn. That vagal response is real and can cause a dangerous bradycardia. Temperature control sounds simple, but it's vital. Keep them warm and dry, aiming for 36.5 degrees. A really key change in recent years is with ventilation. We always start PPV with room air. We only jump to 100% oxygen if we have to start chest compressions. Now for drugs. Epinephrine comes into play if the heart rate stays below 60 after good ventilation and compressions. The IV or IO dose is 0.01 to 0.03 milligrams per kilogram. But look at that endotracheal dose. It's significantly higher, 0.05 to 0.1 milligrams per kilogram. And one more thing. Naloxone is a no-go for the initial response. It's just not recommended.
Okay, let's zoom out a bit and talk about the core principles of pediatric arrest. This is so important because pediatric arrests are fundamentally different from what we see in adults. They are almost always asphyxial in nature, meaning they're the end result of progressive respiratory failure or shock, and that fact changes everything about our approach.
You know, it's really helpful to think about this whole process as a timeline with 4 distinct phases. First is the pre-arrest phase. Our goal here is simple: protection. We want to prevent the arrest from ever happening by spotting trouble early. But if an arrest occurs, we enter the no-flow phase. Here, the goal is preservation. We have to minimize the time until CPR starts. Then comes the low-flow phase. This is when we're doing CPR. The goal is to resuscitate by pushing blood to the heart and brain. And finally, if we get them back, we're in the post-resuscitation phase, where our job is to optimize their recovery and protect the brain from reperfusion injury.
This brings us to a classic debate, CAB versus ABC. Now, the guidelines have officially shifted to CAB, circulation airway breathing, to create one universal algorithm and make sure nobody hesitates to start compressions. But let's be real. For pediatric arrests, which are mostly about a lack of oxygen, ventilation is still incredibly important. And in our world, in the operating room, we have a whole team. We don't have to choose. We can, and we absolutely should, do it all at once. Start compressions while someone else manages the airway and ventilation. We get the best of both worlds.
No matter the sequence, high-quality CPR is the one thing that is completely non-negotiable. And that means hitting our numbers. The rate is easy, 100 to 120 compressions per minute for everyone. Depth is critical. You have to go at least 1/3 the depth of the chest, which is about 4 centimeters in infants and 5 in children. If you have 2 rescuers, the 2-thumb encircling hands technique is hands down the best for infants, and our ratio is 15 to 2. And woven through all of this are the key principles: push hard, push fast, let the chest fully recoil, and keep those hands off the chest interruptions under 10 seconds.
Okay, now for the new stuff. Let's dig into the 2025 updates to basic life support. These are important changes that are really aimed at making those first actions, before any advanced care arrives, as effective as they can possibly be.
The 2025 BLS updates really focus on what works, and this is a big one. The two-finger technique for infant compressions is officially out. It's just not effective at getting the depth you need. So now you should use either the one-hand technique or, preferably, the two-thumb encircling hands technique. The guidelines also double down on getting an AED on the child immediately. But maybe the biggest change is with foreign body airway obstruction, where we have totally new sequences. And finally, they're reminding us again, for healthcare pros, that pulse check is 10 seconds, max. If you're not sure you feel a pulse, you start compressions, period.
This is so important. This table shows the new standardized approach for severe choking, and it's now crystal clear. For an infant, that's anyone under 1 year, you do repeated cycles of 5 back blows and then 5 chest thrusts. And the key change here is what you don't do. Absolutely no abdominal thrust for infants. The risk of injuring their organs is just too high. For a child over 1 year, the sequence is now 5 back blows followed by 5 abdominal thrusts. This brings them in line with the adult guidelines and makes it much simpler to remember in a stressful situation. This is a fantastic clarification.
All right, building on that strong BLS foundation, let's move into advanced life support. This is where we, as anesthesiologists, really bring our unique skills to the table. We're talking pharmacology, advanced monitoring, post-arrest physiology. This is our world.
So what are the high-impact changes for PALS? First, for those non-shockable rhythms, asystole and PEA, the message is loud and clear. Give epinephrine as soon as you possibly can. For shockable rhythms, the defibrillator is still your best friend, but if there's any delay in shocking, give epi. Now here's a true game changer. We now have specific physiologic targets for CPR. If you have an ART line in, you should be aiming for a diastolic blood pressure of at least 25 in infants and 30 in children. This is huge. It gives us a real-time number to track how well we're perfusing the heart. After the arrest, preventing fever is a top priority. And finally, the guidelines really stress that predicting neurologic outcome is a complex process. You can't rely on any single test.
So you'll see these recommendations are all graded. This grid basically tells us how strong a recommendation is and what kind of evidence is behind it. Class 1, in green, means go for it. The evidence is strong. Class 3, in red, means don't do it. There's no benefit or it could even cause harm. And the level of evidence tells you if this is based on big randomized trials or just expert opinion. Understanding this helps us know the why behind what we're doing.
So let's really zero in on the key medication and monitoring updates. We've talked about early epi for non-shockable rhythms. For shock-refractory VFib or pulseless VTAC, you can consider either amiodarone or lidocaine. The evidence doesn't really favor one over the other right now. But here's what's critically important. Routine use of calcium and bicarb gets a Class 3 recommendation. That means don't do it. There's no benefit and potential for harm unless you have a very specific reason like known hyperkalemia. And I'll say it again because it's that important. Using that ART line to target a diastolic pressure gives us an objective, real-time measure of our CPR quality.
Okay, so we've got all these principles and updates. Now let's see how they all fit together in the clinical algorithms we use right at the bedside. Think of these as our playbook in a crisis. They give us a clear, structured path to follow when things are chaotic.
This is the big one, the pediatric cardiac arrest algorithm. It looks complicated, but it really breaks down into 2 main roads. You start with high-quality CPR, then you look at the rhythm. Is it shockable? If yes, VFib or pulseless VTAC, you go down the left side. You shock, you immediately get back on the chest, and after the second shock, you give epinephrine. If the rhythm is not shockable, asystole or PEA, you go down the right side. This path is all about continuous high-quality CPR, getting that epinephrine in as early as possible, and then just cycling through every 3 to 5 minutes while you frantically search for and treat any reversible causes.
Now, what if the child has a pulse, but it's slow and they look terrible? That's when we turn to the bradycardia algorithm. First things first, you support their airway and breathing. Then you look for signs of compromise. Are they hypotensive, altered, showing signs of shock? If the answer is yes, and their heart rate is under 60 despite good oxygenation, you start CPR. And this is the part that can feel weird. We are starting compressions on a patient who still has a pulse because that pulse is just not enough to perfuse their body. From there, we can give epinephrine or consider atropine for vagal-mediated issues.
And finally, we have the tachycardic patient. This algorithm really hinges on 2 key questions. Is the QRS wide or narrow? And is the patient stable or unstable? If it's a narrow QRS, probably SVT, and the patient is stable, you can try vagal maneuvers. If that doesn't work, you give adenosine. But if that same patient with SVT is unstable, you skip all that and go straight to synchronized cardioversion. If the QRS is wide, it could be VTAC. If they're unstable, it's immediate synchronized cardioversion. If they're stable, well, that's when you can consider some drugs, but you should definitely be getting an expert opinion fast.
So what happens when conventional CPR isn't working, or when we finally get a pulse back? That's when we enter the advanced frontiers of resuscitation. This is where the focus shifts from just restarting the heart to preserving organ function, especially the brain, and optimizing for long-term neurologically intact survival.
ECPR, or ECMO-assisted CPR, is a highly advanced, resource-intensive therapy. It's basically putting a patient on heart-lung bypass during a cardiac arrest when nothing else is working. It can be a lifesaver for very select in-hospital patients, especially those with known heart problems. But it's a huge decision, and before you even consider it, you have to ask 3 questions. 1. Is there a reversible cause we can fix if we just buy some time? 2. Can ECMO actually bridge this patient to a good outcome, like a transplant or recovery? And 3. Do we have the team and the system ready to go right now to deploy it rapidly?
You know, getting ROSC, return of spontaneous circulation, feels like victory, but the battle is really only half won. Now we have to fight reperfusion injury, and that means a coordinated attack on multiple fronts. First, we aggressively prevent fever, keeping their core temp below 37.5. Second, we maintain perfusion, using an ART line to keep their blood pressure where it needs to be. Third, we meticulously manage their oxygen, walking that fine line to avoid both hypoxia and hyperoxia. And finally, we have to monitor the brain. Continuous EEG is now recommended because non-convulsive seizures are incredibly common after an arrest, and they can cause a ton of secondary brain damage if we don't catch and treat them.
So we've walked through it all. The new sequences, the updated drug timing, the new physiologic targets. We have clearer guidance and better tools than ever before. But these guidelines, they're the floor, not the ceiling. The real goal has shifted. It's no longer just about survival, it's about neurologically intact survival. So the question I want to leave you with is this. As we take these new guidelines back to our practice, how can we truly leverage advanced monitoring and, even more importantly, our team dynamics to not just improve survival rates, but to truly optimize the long-term neurologic outcomes for our very youngest patients?